Hi, my name is Jack West. I'm a medical oncologist in Seattle, Washington, and I'm also the president and CEO of GRACE, the global resource for advancing cancer education. I'm very happy to be here tonight with Dr. Mark Socinski, a guest faculty member who is a professor of medicine and the leader of the multidisciplinary Thoracic Oncology Program at the Lineberger Comprehensive Cancer Center at the University of North Carolina in Chapel Hill, which is really one of the leading programs in the country and world in thoracic oncology. And Dr. Socinski personally has led some of the many influential, really seminal trials and continues to do so. We will be talking about some of the work that he's been deeply involved with in further discussions from ASCO this year and probably many in the future. I'm happy to have him talking today about a controversial and open question about timing and optimal selection of therapies to be pursued after the first-line setting. Really the question of what is the role today for maintenance therapy. So Dr. Socinski will cover that question, and after his presentation we will open things up for questions from people. I'll mention also that the program is made possible through an educational grant from Eli Lilly Oncology, and they had no direct role in the development of its content, but we do thank them for their support. We will be making this program into a podcast. If people miss things or just want to catch it later, it will be available for download with transcripts and figures. So with that, I will turn it over to Dr. Socinski if you want to take it from here.
Okay, thank you, Jack. It's a pleasure to be here with this audience and to talk about this new concept of maintenance therapy, and I'll give you sort of my view of it as we go through this presentation. It's really amazing to me that we've had 4 major trials that have really addressed this, as well as the approval of a very important drug, that being Avastin or bevacizumab, in the treatment in which we continue this drug in a maintenance fashion. So this is a big new topic that we certainly weren't talking about a year or two ago, and so it's really a new subject. This slide just summarizes my disclosures in terms of research support and Speakers Bureau, and as Jack mentioned, this is supported by a generous grant from Lilly Pharmaceuticals. So the drug names that I'll be using in this presentation, I tend to slip back and forth between the brand name, which I've listed on the left, and then the generic name, which I've listed on the right. So Avastin is bevacizumab, Erbitux is cetuximab, Alimta, pemetrexed, Tarceva, erlotinib, Taxotere, Docetaxel, and Iressa, gefitinib. Well, what I will try to do is to use the brand names on the left-hand side, although some of the slides may contain that, and I'll make comments throughout the presentation to make sure that people can follow this. So I think it's important to start with what we really know about treatment paradigms, what's established in the treatment of advanced non-small cell lung cancer. I think it's very clear that treatment with platinum-based therapy clearly changes the natural history of this disease and clearly makes patients live longer. I think we know that the benefit of platinum-based therapy is achieved relatively early, usually within the first 3 or 4 cycles, in that prolonging therapy with platinum-based regimens does not necessarily yield clinically relevant benefits. We also know that over the past 5 years or so that 2 important targeted agents, when added to platinum-based treatment, improve survival in the first-line setting. The first, Avastin or bevacizumab, and the second, Erbitux or cetuximab. Now, Avastin is the only one approved to date. Erbitux has not yet gone through the approval process, but that may happen in the near future. For the past 10 years, we have accepted the fact that following a treatment with first-line platinum-based therapy, and when the tumor seems to be getting worse, that using selected single agents is known to improve survival compared to either best supportive care or placebo. And we have 3 drugs that are approved for use after first-line therapy, that being Taxotere or Docetaxel, Alimta or pemetrexed, and erlotinib or Tarceva. We also know that chemotherapy, in this treatment that I'm referring about, has a palliative effect in symptomatic patients across multiple lines of therapy. So symptomatic patients can feel better with first-line treatment, and we've documented that, and we've documented it in the second and third-line treatment also. The issue is that all of these treatments have toxicity, cost, obviously the inconvenience for patients adhering to a treatment or assessment schedule. We tend to ask a lot of our patients in terms of getting blood tests and scans and x-rays and those sorts of things. And it is a lot of commitment to go through these sorts of things. And I think it's important, at least in advanced disease, as I try to stress to my patients when I first meet them, is that this is a very treatable disease, but it's not necessarily a curable disease in the vast majority of patients. And so our goal, really, is how do we make this more of a chronic disease by using multiple lines of therapy and trying to figure out what's the best thing to do first, second, and third line, and do that with acceptable toxicity so that we kind of transition this from, when untreated, a potentially very rapidly fatal disease to more of a chronic disease and try to keep the cancer at bay with acceptable side effects of our treatment. Well, I think we know all those things, or accept those sort of things. What are the things that aren't necessarily established in the treatment of this disease? Well, one of the issues is the use of Avastin or bevacizumab and Erbitux or cetuximab, even though they were studied in a manner to continue them as maintenance therapy. We actually don't have a trial that really establishes how much value our patients are getting by stopping the chemotherapy, for instance, and then continuing Avastin. That's the way the initial trial was performed and done, and so we tend to do it, but we really haven't really established the true maintenance role of either Avastin or Erbitux in this setting. Likewise, all of these treatments that we've been discussing work well in a substantial minority of patients, but not all the patients. And it would be nice to test either the patient or the tumor and be able to identify a so-called biomarker or some blood test or test of the tumor that evaluates which patients are going to get greatest benefit, and probably, at least important, those patients that with a specific treatment are not going to get much benefit. I think we do have an example of EGFR mutations, which we won't dwell on specifically tonight, but I think there is a biomarker that identifies the patients that get great benefit from drugs like Tarceva. We also know that historically what we've done is to give first-line therapy and then give patients a treatment break and then treat them when we think the cancer is getting worse. And we don't really know optimally how to follow patients. I know what I do in my practice. I tend to see them fairly frequently. I tend to pay attention or let the patient pay attention to their symptoms. I don't do a lot of x-rays or CAT scans or PET scans or a lot of blood tests. But I think we haven't really established what truly we should be doing in that particular setting. And as I mentioned, we have 3 lines of therapy that are approved by the FDA, and you'll hear us referring to them as first line and second line and third line. And I think that we have lots of questions about the most appropriate strategy to pursue when we have multiple active agents and want to give multiple lines of therapy, but what is the best way to sequence them in this particular setting? And I think actually what we need in the oncologic community, both from a patient level as well as a physician level, is getting used to the concept that what may be the most important thing is that patients get treated with drugs that have activity, and that it's important to get multiple lines of therapy. Obviously, if you don't get second or third line, you can't benefit from second or third line treatment, so that kind of follows the rationale for that. The next slide, just one slide, condenses 3 or 4 pages of recommendations from the NCCN. This summarizes the first-line treatment, and we've pretty much said this briefly. They recommend platinum-based doublets with either bevacizumab or cetuximab or Avastin or Erbitux in the appropriate patient. Pemetrexed or Alimta-based therapy is a pertinent consideration for patients with non-squamous histology. And we have, I think, sufficient information that if you identify a patient that has a mutation in the epidermal growth factor, or so-called EGFR mutation, that Tarceva or erlotinib is an appropriate first-line treatment in the United States. The NCCN has adopted the concept of maintenance, but has really a couple of different types of maintenance, and we'll talk about that in a couple of slides or so. As I mentioned, the FDA has approved 3 drugs in the second-line setting, and these are specifically approved for patients who have received first-line treatment with platinum-based therapy, Taxotere, Docetaxel, Alimta, or Pemetrexed, specifically in non-squamous, and then erlotinib or Tarceva. And Tarceva's indication spans the second and third line. So when you look at this, you really have the option of first line, maintenance therapy, second or third line. So this suggests to me that the NCCN is embracing the concept that there are really 4 potential lines of therapy outlined in their current recommendations. Now, I mentioned there have been a number of agents tested, and I've mentioned the 3 that are approved in the United States by the FDA, Docetaxel or Taxotere, Pemetrexed or Alimta, and erlotinib or Tarceva. Erlotinib is the oral agent that targets the EGFR protein, if you will. Again, some of the considerations in thinking about this, if 3 or 4 cycles of platinum-based therapy really is the optimal approach in the first-line setting, what do we do beyond that? What do we do next? What are the considerations regarding maintenance versus second-line therapy? The agents that we've talked about before, both Taxotere, Alimta, and Tarceva, I think it's important to note that they're all approved based upon an improvement in overall survival as well as a palliative advantage compared to either best supportive care or a placebo. Now, historically, we have given these agents that are approved by the FDA at the time that the cancer is getting worse. That's just how they were initially studied. But some of us have always felt, why wait till the cancer is getting worse? Is there a role for giving them earlier? And that would kind of come as a maintenance sort of strategy. And just so we understand the definitions of the NCCN guidelines, they have 2 types of maintenance. And one is really in the consideration of a drug like Avastin, where we give Avastin with chemotherapy initially, and we give 4 or 5, 6 cycles or so, then we stop the chemotherapy, but we continue the Avastin. And so we would refer to that as continuation maintenance. Whereas if you're doing switch maintenance, you're really integrating, say, after 4 cycles, a new agent, one of the approved second-line agents. And so you're really switching to a new agent as your maintenance agent in this particular setting. And actually, we now have 4 trials. I mentioned in my introductory comments that we have a lot more data to talk about this, and I've listed on this slide that's titled Timing of Second-Line Therapy here, the design of the 4 trials. And if you look at the far left of this slide, we see these are patients who have been previously untreated. They're chemotherapy naive. They have advanced non-small cell lung cancer. They are treated with 4 cycles of platinum-based therapy in this setting here. And then in the design of these trials, if you made it through your 4 cycles and your cancer was stable or better, then you were randomized to receive, on the bottom here, delayed second-line therapy, which we would argue would be the standard of care. That you would get your 4 cycles, you would have a treatment break, and then you would get docetaxel or other therapies at the time your cancer was getting worse. And so delayed second-line therapy would be considered the standard of care, if you will. The top part up here is really the integration of immediate second-line therapy, and all of these trials have been referred to as maintenance trials because presumably your 4 cycles of chemotherapy have stabilized or decreased the tumor, and what you're doing is using these agents, Taxotere, Alimta, or Tarceva, to maintain the benefit that you received from your platinum-based therapy in the first-line setting. So even experts, and Dr. West will attest to this, I don't know that there's universal agreement about what to call this. And I've sort of paraphrased the question on the bottom. Is this maintenance therapy? Is this sequential therapy? You're going from treatment A to treatment B. Is it just prolonged therapy? You're just giving a longer duration of therapy. Or is this really integrating effective second-line therapy earlier? And I think all of us have our opinions about how we think about this, and we'll discuss this as time goes on. Now, it's important to note that there are some patients in this initial part of the treatment that don't make it through 4 cycles, and their cancer gets worse. They progress despite getting chemotherapy, or they have significant side effects of treatment that they can't make it through the 4 cycles. And so we have to remember that this really just applies to patients who successfully complete 4 cycles of treatment. Now, I'm going to walk you quickly through some of the trials, and this is the initial trial that brought this concept to our attention. So we call it the Fidias trial. It was published a few years ago in the Journal of Clinical Oncology. And you see right here, patients with advanced disease were given 4 cycles of chemotherapy with a very standard regimen, carboplatin plus gemcitabine. If you had a response, your tumor shrank or was stable and didn't get worse, you were then randomized to getting, on the bottom here, delayed docetaxel, which we would assume to be the control arm. Or rather than wait till you progressed, you would get immediate docetaxel or Taxotere on the top arm. And that was the design of this trial. We see that one of the observations in this trial, I'll just draw your attention on the bottom part here. When you randomize patients to delayed Taxotere, you see that of the 154 patients that were randomized, only 91 of them received delayed treatment. So there's a fair drop-off of patients because they typically have disease-related problems that preclude them getting delayed treatment. So that's a real issue. Obviously, if you don't get the delayed treatment, you can't get benefit from it. On the top part, if you decide to do it immediately, you see of the 153 patients, 142 received immediate treatment. So a much higher percentage received treatment that we think is effective second-line treatment. Did it make a difference? Well, this is what we refer to as a Kaplan-Meier curve. This looks at progression-free survival. This would be how long you live before your cancer gets worse. And you can see the blue line is much better than the red line. And the blue line is the patients that received immediate treatment. And the red line are those patients that received delayed treatment. You can see there's an obvious difference between the two. For those of you interested in statistics, the p-value over here is highly significant. But we would argue that you don't have to be a statistician to realize that the patients on the blue line are doing much better than the patients on the red line. That's with regard to when your cancer gets worse. If you look at the overall survival of patients, how I interpret this trial is that there's a separation of the curves and a persistent separation of the curves for a relatively long period of time in favor of the immediate treatment. Now, we know the patients on the immediate treatment arm more likely received effective treatment with Taxotere versus the patients on the blue line. Now, when you look at the absolute numbers, the average patient lived nearly 3 months longer, and at 12 months, or the 1-year survival, there was about a 10% difference. And I personally believe that this is very clinically meaningful in this particular setting, although the p-value was not quite to where we'd like it to be so that we could firmly say that this is a clearly positive trial. In my mind, this is a clinically positive trial in a meaningful way, but from a statistical point of view, it's just not quite there to statistical significance. Now, one observation made on this trial was in those patients that actually received immediate Taxotere as well as delayed Taxotere. You see, if you actually got the Taxotere, your survival was the same. There was no difference. So it suggests to many of us that what this trial really reaffirmed was that it's important to get subsequent second-line therapy, and whether you get it early or whether you get it late, it doesn't seem to matter. It still benefits you in the same manner. The risk is that if you wait to give it, a lower percentage of patients actually receive it. And so that's a real issue that we have to face in our clinical practices. A second trial used pemetrexed or Alimta, a very commonly used drug in non-small cell lung cancer. It had the same design. You see here patients received 4 cycles of platinum-based therapy. If you didn't progress or your cancer was stabilized or maybe shrunk a bit or maybe a significant amount, you were then randomized in this trial to placebo. And when you progressed on placebo, you could get second-line therapy versus Alimta, so active treatment. And again, remember, Alimta is approved for the use in the second-line setting. Now, in this trial, they were interested in looking at how long it took the cancer to get worse or progression-free survival as the primary point of interest, but overall survival was the secondary point of interest. On this trial, you see here, just like in the Fidias trial, when you look at progression-free survival or the time it takes for the cancer to get worse, it was significantly in favor of the early use of pemetrexed versus placebo in this particular setting, a doubling of the average time, 2 months on the placebo and 4 months on the Alimta arm, which I think is, again, statistically significant and I think quite clinically meaningful to patients as well as physicians. What was very interesting, again, is we saw the same thing that was in the Fidias trial, but this trial was much larger. So actually, this difference in overall survival in favor of the blue curve compared to the white, the blue curve were those patients getting Alimta as so-called maintenance, of about 3 months. Remember, I alluded to this on the Fidias trial, where the difference in median survival was about 3 months. And we see the difference in 1-year survival is in the range of 10%, much like it was in the Fidias trial. So I've always felt that the results of the Fidias trial in this trial were very similar. The Fidias trial was a smaller trial and didn't achieve statistical significance. This trial did. You see the p-value here is less than 0.05. But the absolute numbers were very similar, and I think the clinical impact of both of these studies is fairly consistent between the two of them. Now, one thing to remember, we know that Alimta is a drug that is much more effective in patients who have non-squamous histology compared to those patients with squamous. That was not known when this trial was initially begun, and therefore when you looked at the benefit of maintenance Alimta, it was really concentrated in the non-squamous patients, whereas the squamous patients did not seem to get any benefit from this agent in this trial compared to placebo. Now, we saw in the same phenomenon here, if you look at the placebo arm and you look at when patients progressed on placebo, how often did they receive what we would consider would be second-line treatment? And you see it's only 67%. So that's quite similar to the Fidias trial. And one of the criticisms of this trial is that they allowed physicians to treat patients with whatever they wanted. Now, what I've highlighted here are the drugs that have been tested and are felt to be effective. We could argue about gefitinib a bit, but for the most part, the one criticism is that, well, 100% of the patients on the maintenance arm received Alimta, only 19% of the patients on the placebo arm received Alimta. So there's a major imbalance in the use of an effective agent between the two arms of this trial. So that's one of the flaws of this particular trial. Now let's talk about Tarceva. Tarceva is an oral drug, and we've studied it in 2 phase 3 trials, the so-called SATURN trial, and again we see chemotherapy-naive advanced non-small cell lung cancer patients, 4 lines of first-line chemotherapy. If you had stable disease or responding disease, i.e. your cancer did not get worse, so it would be non-progressive disease, you were randomized to placebo or erlotinib. Again, the primary point of interest was progression-free survival in this clinical trial. Like we saw on the Fidias trial, as well as the Alimta maintenance trial, the progression-free survival was statistically significant and I think clinically significant in favor of receiving Tarceva over placebo. And strikingly, this translated into an overall survival advantage in those patients receiving maintenance or early Tarceva treatment compared to placebo. So again, this trial is very consistent with the Alimta trial. It did show a benefit in the time to your cancer got worse, as well as the overall survival experience of patients who received this versus placebo. Now, in the SATURN trial, much like we saw on the Alimta trial, in those patients who received placebo, you see there are about 30% of patients that never received any subsequent treatment. And like the Alimta trial, remember, everyone that got randomized to the maintenance or erlotinib received it, but if we look on the placebo arm, only about 20% of patients received exposure to a drug like Tarceva. So again, like the Alimta trial, this is a criticism of this trial, that there was a clear imbalance of exposure to Tarceva on one arm versus the other arm of this particular trial. The fourth and last trial is the ATLAS trial, which was identical in design to the previous trial, SATURN, I just showed you. But in this population of patients, these were patients who were receiving Avastin in the first-line setting, or bevacizumab, with their chemotherapy. And as I mentioned in some of my introductory comments, the common practice is to continue bevacizumab as maintenance therapy. So in patients who got 4 lines of treatment and whose cancer did not get worse, they continued bevacizumab or Avastin with a placebo until they progressed, versus the other arm of this trial continued the Avastin like the other arm, but added Tarceva or erlotinib to it. Like the SATURN trial, ATLAS had a progression-free survival of interest, and you see on the next slide that the progression-free survival was improved to the same degree, almost identical degree as on the SATURN trial. So the impact of using Tarceva early on or as a maintenance drug or early second-line therapy, the impact of that was very consistent between SATURN and ATLAS. Now, the one area of confusion, at least to me, is we know that we haven't seen all of the data or all of the information, but whereas SATURN had a survival advantage to the early Tarceva or maintenance Tarceva, we know on ATLAS that there was not a survival advantage. Now, we don't yet have access to all the information about that, but we will be seeing that at an upcoming national meeting, the so-called ASCO meeting that will be happening in June of this year. So that's going to require some further analysis to understand that, because frankly I was expecting the ATLAS trial to be positive for overall survival in a very similar manner to the SATURN trial. What I've done on this slide is to kind of create some food for thought, if you will. And if you remember in my introductory comments, personally I think that if we have all of these drugs that work, it's important for patients to get an exposure to these drugs. Obviously, if you have a drug that works, but the patient doesn't give it, it can't be very helpful to the patient. So if you look on the placebo arms of both the JMEN, which was the Olympta trial, in SATURN and ATLAS, which was the Tarceva trial, if you look at the placebo arms, we see the phenomenon of 100% of patients getting first line, about 55 to 67% of patients getting second line, and actually none of these trials report how many patients received third-line therapy, but in general, I would bet it would be about half the number that received second-line therapy, because we know there's a drop-off going from first to second to third line. Whereas if we look at the patients who received the so-called maintenance arms of these trials, we have 100% of patients getting first line, 100% of patients getting second-line therapy or so-called maintenance therapy, mind you, with a drug that has been approved by the FDA for use in the second-line setting. And then we have roughly 50 to 55% of patients receiving third-line therapy. So one can assume that the exposure to active agents was much greater for those patients treated with maintenance therapy. And we know that certainly on JMEN or the Olympta trial in the SATURN trial, as well as ATLAS, there was a significant benefit in progression-free survival or the time till your tumor got worse. And we know on the Olympta in the SATURN trial that overall survival was significantly increased in that setting. Now, ATLAS is the one flying the ointment with regard to overall survival in this study, but we need to get more information about this. And although I don't have the Fidias trial, which was the Taxotere trial, on this slide, I think the same observation can be made with regard to that particular trial also in terms of exposure. Now, how should we think about this first to second line transition? If we do it early and call it maintenance, or if we delay it, what's the best thing to do? I think it's important to remember that on all of these trials, patients were followed every 3 weeks and had CAT scans every 6 weeks. And again, despite this, 33 to 45% never received second-line therapy. So that's a concern. So I don't think the answer is seeing patients frequently and doing more CAT scans. I think one of the design flaws is physicians that had patients on this trial had to wait until they were completely sure that the cancer was worse. If they suspected the cancer was worse but couldn't prove it, they couldn't treat patients in the second-line setting. So I think we need to explore many of these regions. We need to sort out who are the patients that progress in a way that they don't get treatment. Can we identify them? Would earlier treatment make a difference in these patients' survival experience? And also, I think it's important. In my practice, I have a number of patients that may enjoy 4, 5, 6, 7, 8, sometimes 9 months of a treatment break, of being off treatment before they transition to second-line therapy. And I think you're assuming that your cancer is controlled. I think your quality of life is always better off of treatment than it is on treatment. Again, this slide just summarizes the 4 trials we've been through. I think I've made all of these points. It's there for you to look at if you want to, but I'm not going to go through this in detail. But this is a slide I put together because I do think we need to think differently about this. Prior to the 4 trials we've just talked about, our standard of care was to give first-line treatment, and then once we thought the cancer was under control, to observe patients, and then when they progressed, we would utilize second-line treatment. We know from historic data, as well as the data from these 4 trials that we've just discussed, that if you do that, you're going to lose about a third of your patients that will never get treated. And so I think it's time to rethink this. Maybe it's best to give first-line therapy and then give second-line therapy immediately. And this, in my opinion, is what these trials did. They randomized patients to maintenance therapy or early use of second-line therapy. And so we know when we do that, that almost all patients get treated with effective second-line therapies. And we now have these 4 trials that I've just discussed with Taxotere, Alimta, and Tarceva, all of which are approved agents for the second-line setting. What these trials have done is simply have used them earlier, and I think that that benefits patients. I would argue that perhaps not every patient with this disease needs to be treated immediately, and that there may be some patients in which you can delay second-line therapy and let them enjoy a break in treatment. And again, I think time off therapy can be very beneficial for patients and very enjoyable for patients because they aren't tied to a treatment schedule. They have more freedom. They can travel. They can do things they want to do. And I think that those are meaningful things for many patients. The question is, how should we best follow them? Because certainly the risk of a treatment break is that something will happen to the patient and they become not eligible for second-line treatment, and therefore they never get it. So I think we have to be careful of that. And remember, I'll show you this slide once again from the Fidias trial, which suggested that whether you got Taxotere immediately or whether you got it delayed, as long as you got it, it benefited you in the same manner. And so I think we need to rethink our approach to this disease, keeping this in mind. So again, my conclusions from this body of literature is that patients randomized to the maintenance or early treatment arms more often got exposed to effective chemotherapy. Patients that were randomized to the placebo arms were less often exposed to second-line and presumably third-line therapy. A benefit in progression-free survival as well as overall survival using these agents that are approved for second-line therapy in patients who have some sensitivity to treatment because their tumor was controlled with first-line therapy, to me is actually really not surprising that they get this benefit. And I would argue we might have already known this from previous trials. And if second-line therapy is delayed, but it's actually delivered, survival outcomes may not be compromised, although that's the message from the Fidias trial, as we've talked about a few times. We need to get more information about this from the Alimta and the Tarceva trials that we've mentioned today. It does seem intuitive to me that if you give treatment or expose patients more often to multiple lines of therapy that is effective, that's going to benefit patients and will be reflected in improved survival. We need to figure out how we make sure patients get second and third line therapy, but I think giving patients a treatment break certainly is a reasonable option in selected patients. Sequencing to approved second-line agents immediately following first-line therapy, which is essentially what these trials did, certainly is known to increase exposure to multiple lines of therapy. And I think it's important to admit that this strategy does have an impact on the natural history of the disease. It improves the time to your cancer getting worse. It improves your overall survival. And so I think that those are important things to consider. So in terms of maintenance therapy, when? Well, this is obviously for patients who have received 4 cycles and had control of their cancer. Their cancer did not get worse. Who should get maintenance therapy? Well, I think patients you are worried about for one reason or another. If you're concerned that the impact of their first line of therapy was less than you wanted it to be, then they should probably get maintenance therapy so they don't get sick faster than you'd like them to get sick. On the other hand, if you treat patients in the first-line setting and they have a very impressive response and they feel much better and they're just very active and feeling well, I'm not quite sure they actually need maintenance therapy. They might be able to delay treatment till a later time point. What we should be using in the maintenance trials is exactly what was used on these trials. Why should we be doing this? Because these phase 3 data do convince us that if you use therapies early in the maintenance setting, that you do have an impact on the overall survival and the time to the cancer getting worse. So I think that that is important to note from these trials. And then what's left? Well, obviously, if we're using approved second-line agents in the maintenance setting, then I typically use next what I haven't used in the first line or in the second line. And so I think that you still have an option for what to do after patients' tumors are getting worse despite maintenance therapy, and we still have some options left for these patients.
Well, great. That was terrific. A very elegant presentation on a challenging topic to get people's heads around.